Thank you, Susan. I really appreciate your introduction. And after that introduction, I'm really tired because that's a lot of stuff. um, so, at any rate, I have actually moved on to a new chapter in my life. And when I started doing this lecture, I was in the midst of a move to a new practice called Animal Samaritans, which is a not-for-profit veterinary clinic in Thousand Palms, California, where I live. Well, I'm in Palm Springs, but either way. But what I'd like to talk to you today about is NT-proBNP, which everybody here listened to my bio and you notice that I have expertise in the area of endocrinology, not actually cardiology. And so I started thinking about this when I was researching this particular subject for this lecture because I gave it at ACVIM. And I started looking at papers and everything. And lo and behold, it turns out I published a paper on this topic. In fact, I published the first paper on natriuretic peptides. We actually measured ANP, which is actually the base particle that is active in the NT-proBNP. It just turns out that NT-proBNP is an easier assay to do because the one we did on the ANP was very, very difficult technically. So I just wanted to give you guys a little bit of background. So now I'm at Animal Samaritans, and I'm just giving you my speaker disclosure because they needed that for ACVIM. So, oh, and then there's one other thing I wanted to tell you about. Let me go back for a second. So this is my standard poodle, Lily, right here with me. And one of the reasons I took the job at Animal Samaritans is that they work with guide dogs of the desert, of which 60% of their guide dogs are standard poodles. So I couldn't turn down a job where I got to see standard poodles every day, including my own, of course. All right, so let's talk about NT-proBNP. And I've kind of separated the scenarios where you might want to use NT-proBNP, and we'll talk about each of these categories as we go through. In the past, probably the most common use of NT-proBNP in general practice is in a situation, an urgent or emergency situation, where you need to differentiate between respiratory and cardiac causes of cough or dyspnea in particular, or exercise intolerance. So that's how most people use this, and it's often used in the emergency setting for that. The second thing that proBNP can be used for is in looking at elevated NT-proBNPs as an indicator of cardiac conditions such as mitral valve disease or tricuspid valve disease and dilated cardiomyopathy in animals. The test we're going to talk about today is a canine NT-proBNP, but hopefully they're working on a feline one as well, and there are some commercially available for that. It's also a useful tool for monitoring the onset and progression of congestive heart failure during treatment. And because this is such a new test, you'll see that I had to use my husband's NT-proBNP data to show you how treatment of heart failure can be monitored by NT-proBNP because they use this in human medicine, and I happen to have that data, so I'll show you that. And then the paper that we actually published on ANP back in 2003, I believe it was, that was a paper that actually looked at using this compound as a prognostic indicator of survival in patients with heart failure. So that was some very interesting data, and I'll cover that as the last topic that we talk about today. So what is NT-proBNP? ProBNP rather. So you can see here's our paper where we looked at plasma natriuretic peptide as an indicator of prognosis in dogs with cardiac disease, and that was published in the Canine Vet Journal, or excuse me, Canadian, not Canine, Canadian Vet Journal in 2003. There's also a very nice paper on N-terminal proBNP in dogs and cats, and it's a technical and clinical review by Lima and Ferrari. And that article is more recent, 2017 in Vet World. So if you guys are interested in getting more information. Basically, canine NT-proBNP is a biomarker, and it has significance in the diagnosis and management of heart disease. And basically, it's produced by both the atria and ventricle of the heart in response to increased wall stress. So when I was at ACVIM, everybody kept coming up to me and saying, "Why are you speaking on a cardiac topic?" And I said, "Because the heart is actually an endocrine organ." And when I initially started looking at ANP, it was back in the 90s when I was doing my master's degree in nephrology. And at that point, they were really looking at ANP and BNP in the scenario of renal disease. And I'll mention something about that, but it's turned out to be not as useful for renal disease as it was for heart disease. So I sort of backed into looking at this endocrine aspect of the heart. So this is obviously taken from human medicine, where you see a lot of heart damage as a result of atherosclerosis, heart attacks, things like that. But it kind of gives you an idea of when you have heart injury, what kind of compounds are secreted into the bloodstream and can be measured in order to assess the extent of the heart damage and also the progression of the heart disease in humans. So you see right at the top, we have NT-proBNP or MR-proANP, and those are going to be measured to try to differentiate in an acute situation between a respiratory cause like a pulmonary embolism or an actual heart attack or other heart injury. The other components we're not going to talk about today, but you guys are probably familiar with things like cardiac troponin, which is released from the cardiomyocytes after injury. And that can indicate if you have a heart attack that's happened and sort of the extent of it based on how high that goes. And you can see that there are a variety of other compounds that can be released after heart injury, including ABP, cardiac, BPC, GAL3, and all of these compounds that are involved in inflammation and fibrosis after an infarction with an acute ischemic injury to the heart in humans. But let's concentrate on the BNP right now. So from a cellular standpoint, like all hormones, these hormones have receptors that sit on the plasma membrane, and they are small peptides that bind to those receptors and then cause an increase in GTP or cyclic GMP. In the case of AMP and BNP, these compounds cause a natriuretic effect. So what I like to say is that BNP and AMP are basically the body's own Lasix. So it causes the kidney to reabsorb less sodium. And when sodium is excreted in the kidney and into the urine, water follows naturally. So wherever sodium goes, water follows. So it produces a pretty profound diuresis. The next effect that these compounds have is a generalized vasodilation, but they also cause anti-proliferation and anti-fibrosis. So in the case of cardiac injury, they don't allow the clot to progress and cause scarring in the heart. So they're helpful, they're anti-inflammatory basically, and they reduce cardiac hypertrophy. So they have some pretty strong effects. Some of the other compounds they haven't been completely elucidated yet, like CNP, and you can see there's some things that seem kind of weird, like anti-dwarfism and fertility, bone growth, etc. I don't know why those would be released, by the heart, but there's going to be more research in that area. But we'll focus on this little green box right here and talk about how these compounds work together in the body to control basically blood volume and blood pressure. So I have this little schematic here, and the way that I think about NT-proBNP is that it's the opposite of angiotensin. So let's talk about the renin-angiotensin system first, because most veterinarians are very familiar with this. We often use ACE inhibitors and also um, angiotensin receptor blockers like telmisartan, losartan, valsartan, those types of things to try to tamp down the renin-angiotensin aldosterone system in patients with heart failure and kidney failure too. So when we have a reduction in blood volume and a reduction in atrial stretch, that leads to reduced blood flow to the kidneys, and the kidneys release renin, which then causes the release of angiotensin, which is converted to angiotensin 2, which then has a direct effect on blood pressure to increase the blood pressure and then help to restore volume into the heart because you're not vasodilated anymore. So it actually increases afterload, so it can increase blood pressure. The second effect of angiotensin is to cause release of aldosterone from the adrenal glands. See, I told you it's all about endocrinology. And aldosterone has the effect of increasing renal sodium reabsorption. So as we know, if you're Addisonian and you don't have any aldosterone, you lose sodium, and clinically you see hyponatremia and hypochloremia as a result of decreased aldosterone. So increased aldosterone actually causes increased sodium in the blood, and that helps to restore blood volume because, again, you're not excreting as much sodium into the urine, and that's going to be reabsorbed, and the water is going to be retained in the body. So that's one half of the system. So then if we look at the other half of the system, we're going to talk about NT-proBNP. The first effect of that as a result, and these compounds are produced as a result of a stretching of the atria or ventricles, and the cardiac wall actually releases these granules. That proBNP actually has a direct inhibitory effect on renal sodium reabsorption. You see, here's a negative feedback right here. So that's going to directly increase the amount of sodium that is excreted in the kidney. So as I said, it acts like nature's Lasix. And then it also has a decreased or a direct effect on renal reabsorption of sodium. So again, that's going to contribute to the natriuresis in addition to its inhibition of aldosterone-related sodium reabsorption. And it has a direct effect on receptors in that control blood pressure in the small arterioles, and there is a direct vasodilatory effect. All of those things basically reduce the blood volume that's returning to the heart and then that reduces the stress on the ventricles so that they go back to normal. So really, their BNP and angiotensin are two halves of the same coin, and they're basically working together or against each other, depending on the situation, to control blood volume and blood pressure. Now, these compounds can be quite profound, and in human medicine, they have concentrated on using drugs that, like Entresto, for example, which is a combination of an angiotensin receptor blocker, I think it's valsartan, I believe, and then there's a compound in Entresto that actually inhibits the degradation of proBNP. So they're actually increasing BNP and decreasing angiotensin and it causes a profound vasodilation, so much so that in my husband's case, he was actually fainting and his blood pressure got extremely low. So we had to actually back him off of that drug and put him on just an angiotensin receptor blocker because of that. When I say we, I use the royal we. That's what his cardiologist recommended. So it's not just an academic question. It's actually that there are drugs now that have been developed that target these endocrine abnormalities in heart failure and help to restore blood volume and blood pressure. So now let's talk about point of care testing because this TrueForma is like a lifesaver for me. I was just talking to Susan about this, and we have so much need for these machines in our practice now. I just started, and now they're asking for 2 or 3 more machines to have in the hospital because we were all lined up using them. So it's really great to have point of care testing for all the things that are available in the TrueForma. So when we look at the traditional assays for measuring hormones, we have radioimmunoassay, which is the gold standard. We have chemiluminescent assays that were developed in the 90s. And then with the point of care testing and miniaturization of these machines that measure very, very small quantities of compounds in the blood, they've developed the bulk acoustic wave immunoassay, which forms the basis for the TrueForma point-of-care testing. So the pros of radioimmunoassay is that it's very, very sensitive because you're picking up these minute quantities of radioactive emissions. And so if you have a Geiger counter, basically, and you're counting these things, you can get down into the picomole and nanomole range, of which endocrine testing, it's very important that you be able to get into those ranges. The cons of radioimmunoassay is that they're generally not automated. They're usually done by technicians. They have high variability inter and intra-assay, and there's long wait times for results. So you might have to wait a week for it. And there's also the problem of radioactive waste. If we look at the chemiluminescent assays, which most large laboratories have gone towards, they're more sensitive and more precise than the radioimmunoassay, but they require, for the most part, to be sent out and have a 24 to 48-hour turnaround. In contrast, our point-of-care testing with the TrueForma using the bulk acoustic wave immunoassay, it's sensitive, precise, and most importantly, it's rapid. So generally, the test takes about an hour turnaround once you spin the sample, and then the test itself runs for 15 to 20 minutes. So what I like about using these point-of-care testing scenarios is that my clients get their answer that day, and I can send them home with medication for whatever condition they have. So just to show you, give you an idea what this looks like, it's maybe 12 inches, 8 to 12 inches square little machine. So it doesn't take up much room in the hospital. You obtain the sample, add the sample to the cartridge, and they will send you this machine for free, and then you buy the cartridges. You then insert the cartridge, and then you get your results rapidly. So it's very easy to use. From a procedural standpoint, basically what's happening is that the immunoassay is on a bed that's sitting on a BAW sensor. And what happens is when the analyte, which is BNP in this case, binds to the antibody that's on the sensor, there's actually a frequency shift in the bulk acoustic wave, and that is directly correlated with the concentration of analyte or concentration of BNP that's in the serum. So one of the advantages of this type of technology is it's not affected by things like lipemia and hemolysis because it's actually looking at molecular weight shifts, whereas the chemiluminescent assays rely on emission of light, which can be impaired by things like lipemia and hemolysis. So one of the things we always want to look at when we're talking about hormone assays is what's the precision of the assay. And in general, for a radioimmunoassay or a chemiluminescent assay, what you want to see is, or a bulk acoustic wave assay for that matter, you want to see a coefficient of variation that's less than 20%. And you can see that at different concentrations of BNP, you're getting some very tight numbers, especially here, less than 15% in most of the cases, except at the very high numbers here in serum. And you can see it's been measured in plasma or serum, which you can use for these. There's a little more variation in the serum than there is in the plasma, but it's not significant. So acceptable coefficient of variation, first thing you want to establish in an assay. And then the second thing is you want to use a gold standard. In this case, it was looked at CardioPET-proBNP. And you can see that the TRUFORMA NT-proBNP has a correlation to the CardioPET-proBNP of 0.97. A perfect correlation would be 100%. So 0.97 is very, very good. So we have precision, and we have accuracy, and we have correlation to a gold standard assay. And then if we compare these assays to each other, the time to results for the TRUFORMA is 16 minutes, and for the CardioPET assay, it's 1 to 2 days. And you see they have a very similar range. Maybe the TRUFORMA is a little bit more sensitive, gets down to a little bit lower concentrations compared to the CardioPET assay. If we look at the BNP reference range in dogs, so there's been a lot of different studies done looking at adults versus juveniles. Maybe there's a little bit less in juvenile, 500 to 750 picomoles per liter versus adults where it's 500 to 1280 picomoles per liter in this particular assay. And this assay that was used for these reference ranges was the CardioPET assay. And then the breed-specific values, there were some Labradors, Greyhounds, and Newfoundlands that had some false positive values. They're probably working through some of those breeds to see if it's particular to them or if it's going to affect things significantly. And then finally, we want to interpret BNP a little more carefully in renal patients because, of course, the kidney's involved in sodium natriuresis, et cetera. If you have renal dysfunction, you don't get quite as good an excretion of sodium as you would in a normally function kidney. So this is the huge dilemma that we always have in cardiac versus renal patients, and usually they're both because the heart's affecting the blood flow to the kidneys. So we often get in a situation where you have animal that has pre-renal azotemia from heart disease and also, congestive heart failure, and those things can be difficult to manage. So let's first look at using proBNP, and in this case, obviously, I'm not using the TRUFORMA BNP because it's not released yet, quite yet. It should be out soon, but I wanted to show you this case because it did involve doing serial NT-proBNPs. So this is Kumo. She's a 17-year-old female spayed domestic long-haired cat, and she presented to a specialty clinic for a series of chronic UTIs. What they felt was early renal dysfunction, very mild elevation in SDMA and creatinine, and she was having some intermittent hyperglycemia. They did, because of the kidney disease, go ahead and do some proBNP, which was kind of in the 404 picomoles per liter is actually kind of borderline. It's not really high, but it's slightly elevated. So they didn't really know what to make of it. But about 3 months after the first elevation in the proBNP, it popped up to about 845, which is a little more interesting, and, there was a doubling of that compound. At the same time, the cat was diagnosed with overt diabetes mellitus, and she was put on Bexacat. She did well with the diabetes, and her blood sugar came down because, as we know, Bexacat is a selective glucose transporter inhibitor, and it was causing glucosuria to help lower that blood sugar. But one of the side effects that can happen as a result of that, because you're increasing glucose in the urine, is this cat who had chronic UTIs developed another pretty serious UTI on Bexacat, which resulted in her needing to be discontinued on the Bexacat. At that point, she was started on insulin at a relatively low dose, like 2 or 3 units twice a day. And by the time she came in to see me, she was on 7 units of glargine twice a day. So, right before I saw her, she presented to urgent care for a sudden onset of dyspnea. And on physical exam, she had decreased lung sounds ventrally on both sides. She was referred to the cardiac specialty, and they measured her BNP again, which had risen to 1500. They went ahead and they didn't do x-rays on her. They just went ahead and did a pleural tap and removed 50 cc's of fluid from both sides. Then when she came back to me, she still had the heart murmur. They diagnosed hypertrophic cardiomyopathy based on an ultrasound after the cat was stabilized, after they did an echocardiogram on her. And the cardiologist said, "Deb, you got to figure out what's going on with this cat." And so I looked at her, and she looked pretty normal to me, but when I talked to the client, there was a history that she was having kind of stutter and snoring episodes. And I was very suspicious that this cat, because she had both diabetes and hypertrophic cardiomyopathy, had acromegaly. So we did send off an insulin-like growth factor, and it was sky high. It was one of the highest ones they'd ever measured. So this is an acromegalic cat who initially was decompensating in her kidneys and then went ahead and developed congestive heart failure from hypertrophic cardiomyopathy, which is pretty common in long-standing acromegaly in the cat. She is currently, the owner is currently looking at taking her to Colorado State for CT and then possibly radiation therapy for pituitary tumor. So this is a case where the BNP was helpful in determining whether it was a respiratory or a cardiac cause of the dyspnea, and they were able to address that without, stressing the cat out, getting x-rays, etc., and were able to treat the cat accordingly. The second thing that we talked about is looking at monitoring therapy for heart failure using NT-proBNP. So, in most patients with heart failure, in the case of my husband, he has a cardiomyopathy called an ischemic cardiomyopathy from having a blocked left anterior descending artery. He didn't have a heart attack, and fortunately, it was diagnosed before a surgery, and so they were able to put in a stent, and he never suffered from a heart attack. But he was put on a drug called Entresto, which I actually talked about earlier, which is a drug that increases proBNP and causes vasodilation, and it also has valsartan in it, so it's an angiotensin receptor blocker combination. So he is monitored when he can't get in for an echocardiogram. He is monitored by NT-proBNP. We actually live in Palm Springs, and his cardiologist is at Cedars-Sinai in LA. So it's helpful for the cardiologist to be able to keep an eye on the heart functions. So this scenario in veterinary medicine would be maybe a dog with mitral valve dysfunction that's on drugs for that. I'm spacing on the name of the drug now, but at any rate, if you have a dog that's on therapy for congestive heart failure, then following their proBNPs can be very helpful to determine if they need an increase in dosage or a decrease in dosage or some sort of intervention without having to go straight to an echocardiogram or to alert the cardiologist that they're going to need to do an echocardiogram. So our cardiologist for my husband, he refers to it as a poor man's echo using BNP. So this is a serial BNP measurements from June of 2022 to April of 2025. And you can see the very, very high proBNP at the beginning here of 1500, and it starts to drop with the Entresto therapy. We had to discontinue it for a brief period of time between the March and the November numbers. And in that period of time, it popped up again a little bit over 1,000, and now it's dropped down to 500 by April. And we have one more that actually goes into the normal range in June of 2025. While at the same time, the echocardiograms that were done during that time had gone from low function of about 45% ejection fraction to 55% by the time this BNP at 500 was measured. So it does correlate with the echo with regard to ejection fraction in this scenario of a human patient with ischemic cardiomyopathy. So then the last thing I'm going to talk about is the prognostic value of NT-proBNP. And in studies in human medicine with acute congestive heart failure, they found that elevated NT-proBNP is a very potent predictor for readmission for heart failure or death within 6 months. And they also found that in long-term studies that proBNP concentrations greater than 100 nanograms per deciliter, but less than 1,000, had an 89.4% survival after 7 years, compared with only 23.5% survival in those with BNPs greater than 1,000. I'm really glad I didn't read this paper when my husband was first diagnosed, because his BNP was really, really high. But as you can see with intervention with the drugs, that they worked really well, and he was able to get into the category of the higher survival. I had read a paper similar to this about prognostic value of AMP and BNP many years ago, before I designed this study on looking at plasma atrial natriuretic peptide as an indicator of prognosis in dogs with heart disease. And what we did in this study is we looked at 23 dogs with heart failure during a 12-month study. It was a prospective study, and we measured baseline plasma natriuretic concentrations. The dogs were classified as mild to moderate cardiac disease in group 1, and there were 10 dogs in that group. And there were 13 dogs that had severe cardiac failure, including dilated cardiomyopathy, end-stage mitral valve disease, etc. And so the mean plasma AMP for group 1 was 64 picograms per mil, and for the group dogs, it was 328 picograms per mil. But what I'm going to show you is the actual survival data. And what we found is that if a single dog had an ANP of less than 95 picomoles per liter, they had significantly longer median survival time, with a median of 1,095 days. However, the dogs with an AMP greater than 95 picomoles per liter, their median survival was only 58 days. So we found very similar data actually prior to them doing the human study. Well, they did. That's not entirely true, because I did read one paper where they looked at left ventricular dysfunction in people, and they were trying to predict whether they would go into heart failure or not. And that's how I designed this study. But the other study that I showed you in human medicine, where 89% of them survived after 7 years, that was a more recent study. That was a study done in like 2018 or so. So I don't know if it was kind of a prescient study that we did at this time. All right, so I'm going to stop there, but I'd be happy to answer any questions.